So I am a geriatric psychiatrist at the University of Calgary and have worked, spent a few years in Ontario, so have worked in long-term care there. And I'm originally from Saskatchewan. That's where I did my training in psychiatry. And so um, have also worked in long-term care there. So hopefully there's some people on that I have worked with before. But anyway, I'm glad to see people from all over the country. I have no, I don't think I have any disclosures that affect the content of this presentation, but I do have a number of research grants. I'm a clinician and a researcher, and I have research support from a few different places. Nothing else to declare. This program has not received any financial support other than from the Public Health Agency of Canada, no in-kind support, and no other conflicts of interest to declare. The information is evidence-based, but I'll qualify that because there is not a lot of evidence on this topic. There's barely any at all. And so I've done my best, but I will be speaking anecdotally, to things that I think where it's necessary to provide a practical perspective and where the evidence doesn't exist. All right, so my objectives are to just talk a little bit about what mental health conditions look like in long-term care, what they are, how common they are, to summarize some challenges relating to providing mental health care in this setting, and to talk about some very high-level key principles for management of common mental health conditions. I would love to go into some of the nitty-gritty and specific, but it's just too short to do that. So hopefully we'll be able to touch on some specifics in the case discussion. But in my presentation, I'm going to give you a geriatric psychiatrist, like very high level approach to managing a mental health condition in long-term care. All right, so I was asked to do this presentation. I was asked to present on mental health in long-term care. And so I immediately said, well, on what? And this is such a huge topic. This is what it feels like to me. This is Cascade Mountain in Banff, and the reply from the organizers was, well, the request was for mental health and long-term care, so we don't have something more specific. That's a big task, and I'm going to do my best, but it is hard to cover everything there is to know about mental health. It is such a big issue. So again, we're going to touch on what I think are probably, I'm guessing, is what I see most commonly, and based on that, I'm guessing what might be most interesting or why people want this topic. So this is not evidence-based, this is anecdotal. When I think about mental health, I think about capital M mental health and little m mental health. One is not more important than the other, but hopefully this will resonate with you. It's important when we're talking about mental health and long-term care because everything gets clumped under the same umbrella. And there are two slightly different things when we're talking about mental health. Often in long-term care, we're talking about mental health symptoms. So things like depressive symptoms or symptoms of anxiety, psychological changes, so which are often normal, like adjustment or reactions to stressors, to losses, to aging, to isolation. Little m mental health is very common in long-term care, so much higher than in other community settings. And when I show you some of the numbers, this will make more sense. When I say capital M mental health, I'm referring to very significant or mental health conditions. By definition, a mental health condition is both symptoms of the condition as well as a significant functional impairment. So people day-to-day life is affected. It is impaired. Otherwise we would call this symptoms. That's a key difference. And when I say capital M mental health, I mean major depression, anxiety disorders like generalized anxiety disorder, panic disorder, PTSD, and then what's sometimes collectively referred to as serious mental illness. It's the term I'm going to use because it's a term that's accepted in the literature and in the medical, other health communities, but it usually refers to bipolar disorder, schizophrenia and schizoaffective disorders, as well as other psychotic disorders within what we call the schizophrenia spectrum. So Capital M mental health and long-term care refers to those disorders, serious mental illness, as well as anxiety, major depression, etc. These are much, much less common in long-term care than little m mental health. And that's because they're much less common in any setting. But it should be noted they are more common in long-term care compared to other community settings. Hopefully that makes sense. Still not very common. And mental health in long-term care usually also refers to dementia, to behavioral symptoms of dementia, to delirium, and to substance use disorders. But for the purpose of this presentation and to make it possible within the time frame, I'm not going to be focusing on any of those things. They would usually be under this umbrella, however. All right. So you'll often see that a majority of long-term care residents have a mental health condition. That is usually referring to mental health symptoms, and it's almost always including dementia as a mental health condition. So among mental health conditions other than dementia, the most common are major depression, and the usual figures, it varies a lot, but the average that you'll see that's, I would say, accepted is about a 10% prevalence in long-term care. That is much higher than in the community, but anxiety disorders, there's no clear estimates, about 3 to 11% of long-term care residents, and then much, much higher for milder symptoms of depression and anxiety. So where it's not a disorder per se, but people have symptoms. Figures for that would be anywhere from below 10% to over 80%, you'll see in studies. On average, would be about 30%. As I mentioned, serious mental illness, it's rare anywhere, but higher in long-term care. As far as we know, we don't know very much. This hasn't been well studied. The prevalence in older adults above age 50 is about 3%. And there's some data from the US that suggests the number of residents with bipolar disorder and schizophrenia in long-term care may be increasing. There's conflicting data, so I'm curious to hear what people are noticing in their settings. But we don't have data in Canada that I'm aware of. We know from US data, for example, that the prevalence increased from about 6.5 or 7% to just over 12% over nearly 20-year period. There's a lot of different reasons for that. We won't get into them, but suffice to say the reasons that might be driving this increase are complex. We don't have perfect data, so even where we have data, it's problematic. It's not perfect, and we know that. And the truth is, we really don't know the scope of mental health conditions in long-term care, except I think it is safe to say it is probably higher or a greater issue than in other community settings. All right. So I'm curious, as I said, I wasn't really sure. I was like, mental health is a big topic. I'm curious what people are here for. What are they finding most challenging in their setting? Is it what I described as capital M mental health or little m mental health? What's most challenging or interesting in your long-term care setting?
I think the ongoing stuff that we hear is the big ones, but I think it's the small m mental health that has the most impact on a day-to-day basis.
Mm-hmm.
Thank you for that. I see that there's a poll up, so everyone can feel free to enter their answers. Thanks. If you're not able to access the poll, then please also put something in the chat.
Okay, thank you, everyone. Oh, we just hit nicely 70-30, which I like. Good, that helps me. Thank you. It's interesting that, so I think it's safe to say, echoing the comment, that what's probably most challenging is what you're seeing more frequently. But
Julia, I apologize. I don't think we can see the results of the poll.
Oh, sorry, you can't see the results?
Yeah, but you can just share it with us. Oh, there
Okay.
it finally came up.
Yeah. 70-30, so 30% capital M mental health, So bipolar disorder, schizophrenia, anxiety, depression, and 17% little m mental health. So I was just saying, I think echoing the comment that some of those more frequent, perhaps milder symptoms are actually, more problematic, difficult, challenging, but still some significant interests or challenges associated with the other disorders I talked about. Okay. Anyways, I haven't tailored the presentation specifically to one or the other, but hopefully, again, we can emphasize whichever is more important in the case and conversations. All right, so I'd encourage you to think about mental health as existing along a continuum. Historically, we've thought about mental health as dichotomous. So you either have a mental health condition or you don't. You are a person who has a mental health problem or you're not. And that is not accurate in a more accurate and forward-thinking view of mental health that will help inform how you address it in your setting is how you think about it and thinking about it on a continuum. And so continuum means that any person at any given time can be somewhere on this continuum. So a person who has a mental health condition can have no symptoms of that condition and can have a very high level of well-being. Similarly, a person who has a mental health condition can have many symptoms of that condition and is more likely to have a lower level of mental health well-being. And people who do not have a mental health condition can still move along the continuum. So in the right circumstances, although it's very unusual to develop a mental health condition in old age, as you know, you can develop many symptoms related, that we would call mental health that can be quite problematic or can affect your level of well-being negatively. And so any person can move along this continuum. And that is why things like health promotion or mental health promotion are very important, whether or not you have a mental health condition or problem. And one of the reasons that little m mental health is so common in long-term care, as you guys notice, is that the level of vulnerability is high and the level of stress in long-term care is also high. I don't think I need to explain that, but this is called the stress vulnerability model. So most of our long-term care residents would have biological vulnerabilities, so they may have dementia most commonly, which puts you at higher risk of mental health symptoms or sometimes conditions. You may have a high level of vulnerability as a result of physical health conditions. People have many physical health problems or comorbidities, pain, etc. These put you at higher vulnerability of mental health symptoms. And then long-term care itself, it is a transition, it is a move, it's often isolating. People may not have the family or other support they need, etc. I don't need to explain all the ways long-term care is stressful. So most people in long-term care are moving towards this end of the graph, and that's that is the reason why we see this much higher prevalence of mental health symptoms like depression and anxiety symptoms in this setting. All right. So most residents with mental health conditions, I'm referring to conditions like, disorders, anxiety disorders, mood disorders, et cetera, but this would still apply to residents who have significant symptoms. They do have higher cognitive, medical, and psychosocial needs. So they differ often than the typical long-term care resident, so someone who struggles with, some type of mental health problem or symptoms. People with conditions like bipolar disorder, schizophrenia are at much higher risk for long-term care placement earlier in life. So they are often younger, and that makes their stay in long-term care longer and their needs quite different than your average or typical older resident who is over 80 in Canada. And they often have multiple physical health comorbidities or cognitive impairment that is either due to their mental health condition or sometimes to its treatment, unfortunately. And then there are many, many system challenges. And I think that probably the most significant of which, although arguably, is these distinct systems of care. And so we have a system that has physical health care, we have mental health care, and we have aging care, and then we have long-term care. And it's as if they're all separate systems. There's not a lot of crosstalk, and they each have their own priorities, and usually those priorities aren't necessarily aligned or they're not shared. So long-term care staff have, in studies, expressed, that they lack training in managing mental health, any type, knowledge or experience with it, that often people who have mental health conditions or symptoms require more time. And, time is an important currency in long-term care. So that creates a lot of challenges. And staff often express, fear, burnout, or discomfort in working with people, in particular with serious mental illness. Majority of long-term care residents do not receive psychiatric services. And so in Canadian studies, for example, it's a very small proportion of people who have an identified need who would receive any specialist care. In an older study, this is Dr. Khan was involved in this one, about 37% of administrators in Canada reported absolutely no access to psychiatric services. This is pretty old, but I wouldn't be surprised if it's changed much. Or I would be surprised if it's changed much. Sorry, I don't think it would have changed much. All right, so I'm going to talk just very high level about key principles for management. Whether we're talking about mental health symptoms or whether we're talking about mental health conditions. So mental health promotion is important for all, and that is a big topic. I'm not going to go into the details, but the point is that it's not just for people who are having a problem, because a role of mental health promotion, if we think about people on the mental health continuum, would be to help prevent, where we can, someone from having symptoms, whether or not they have a condition. And if they do have a condition, to, again, as best we can, prevent them from having active symptoms of that problem. And then knowing that long-term care residents are at very high risk, promoting mental health should be a priority to help, again, do what we can to prevent people from developing a more significant problem. So things that are included under the umbrella of promotion would be things like, of course, staff training, personalized care, activities that are aimed at, both mental and physical health, given, for example, the role we know that exercise and isolation play in affecting mental health, access to mental health, etc. There are many, many more things. My point is that mental health promotion is important for all long-term care residents. So in terms of assessment, it is very important to get the history. This is my approach to assessment. And so I think would mirror a lot of how many geriatric psychiatrists and allied health, like the nurses, the specialized mental health nurses I work with, approach mental health. So one, get the history. I think the two key questions are asking, has anything like this happened before in our symptoms now, like they were in the past? And what treatment has been useful in the past? What has not worked and what has worked well? So in terms of getting the history, what's happened before, just a few key points. For mood, anxiety, and psychotic disorder, an initial presentation in older age is extremely unlikely, okay? So it is likely someone might have symptoms, they might have, many other issues like delirium, it might be secondary to dementia or a physical health problem, it might be medication side effects. You have to think of all of these things, but if a person has never had a problem, for example, with anxiety, which is usually a disorder that presents in late adolescence or early adulthood, it is probably not an anxiety disorder. Okay? It's important to know this because you do not want to be, it guides your treatment. You do not want to be missing things that you might need to be treating, and you do not want to be aggressively treating things that are not going to respond to medication treatments. All right, for those who do have a known history of a mental health condition, it's really important to ask, what's their usual, what we call baseline? It might not be the best word, but what are they usually like when they're well, and what is changed, okay? And it is really important to involve family to understand the history, but do not also forget to involve the person. And I say this because I see this often. Everyone is like, they're depressed, or they're this or that, and no one has actually asked the person that we're talking about how they're feeling. And I think it's because there's an assumption that someone's not going to be able to report it accurately. While that is the case for many people, it's also not the case for many people. So I have many patients, for example, with bipolar disorder and dementia who are still very much able to tell me what their mood is like very clearly. And that informs my assessment and my treatment. So in terms of treatment, you want to clarify both medication and non-medication treatments, approaches that have been effective for them in the past will guide your. So non-medication approaches, non-pharmacological treatments are important for everybody, and they need to be part of the treatment plan, so not an afterthought. And that means they're in the care plan and they're clear and they're individualized for that person and for the symptoms or the condition that they're experiencing. I know this is very, very challenging, but this does require broad staff engagement for these strategies to be effective for mental health. So for example, in someone who struggles with depressive symptoms or a major depression, we often recommend behavioral activation, which means scheduling activities, engaging someone. It really doesn't work in long-term care if it isn't part of the care plan and if a number of different staff isn't involved. So for example, if just the doctor is responsible or just the RN, like it's very unlikely to happen on a daily basis. For these to be effective, we really have to involve our PSWs, our rec therapy staff, sometimes our dietary staff. They do not happen usually otherwise. All right. So in terms of treatment, and there's lots more to say about non-medication treatments, but again, I'm just trying to move quickly. I can elaborate if need be. With respect to medication treatment, so keep in mind that not all mental health symptoms or conditions require treatment with medications. For example, psychotic symptoms in someone who has schizophrenia or dementia actually is really guided by functional impairment and distress. I see kind of a knee-jerk reaction sometimes where it's like, they're hallucinating or they're paranoid, like we have to treat them, but actually you don't. What you want to ask is, how much is this affecting them? How much is this impairing them? How much distress is it causing them? And, obviously more significant, in all of those domains, you will lean towards medication treatment. But if it's minimal in all of those respects, you do not have to treat with a medication. Keep in mind that comorbid dementia can complicate treatment response. So often, again, for example, in the example of depression, we know that mild and moderate depressive symptoms, actually all depressive symptoms, respond poorly if the person also has dementia to antidepressant medications. So you have to keep this in mind. You have to be thinking about, is this a problem that responds to treatment with medication when you're considering a medication? And I say this because polypharmacy with psychiatric medications is extremely problematic in long-term care. It's not just antipsychotic, it's all psychiatric medications. We need to be very, very careful. It's not just doctors, it's everybody about how much we're prescribing. So I saw a recent figure, for example, during the pandemic in September 2020, about 50% of long-term, over 50%, it was 52, in long-term care residents were prescribed an antidepressant. It's hard to justify that figure, and I think just speaks to the fact that we have to be very cautious with medications. That being said, you do not want to not treat someone who has a problem that you think is likely to respond to medications, or that's more severe. And so I do see some ageist attitudes about the value of treatment. For example, like, oh, this person doesn't have a lot longer left, or they're declining, they're failing. But if they're failing because they're staying in bed all day because of their depression, the depression is potentially treatable and they might not be failing, so to speak. So that's just an example of being careful of not accepting something as normal or being skeptical or pessimistic about the value of treatment because someone is older or in long-term care. All right. In general, medication, it's too complicated, but how I see it, you know, in any patient that I would see, these are always the questions this is how I would approach it. For someone who's not on treatment, I would think about starting something, you know, guided by those questions I just mentioned. If someone's already on treatment, you always look, is there room to optimize the dose, particularly if they've responded to that treatment before? For someone who's already on treatment, then you would, you know, if it's not possible to adjust the dose, you don't think that's going to be helpful, you would think about either switching, okay, which involves some risk, but helps avoid that problem of medication prescribing and the risks that come in an individual with being on multiple medications. Or you would think about adding like a booster augmenting medication. And then of course, you do not want to forget about evaluating treatment and keeping, you know, treatments that work, obviously, and stopping treatments that don't work and reapproaching, you know, with a different plan. All right. Serious mental illness, I just thought I would mention that it is a lifelong treatment, involves lifelong treatment with medication. So both bipolar disorder and schizophrenia, people can usually not stop their medications, you know, and a problem that comes up in long-term care is that these medications have significant physical side effects, okay, and cognitive side effects. Unfortunately, this is unavoidable, and I hope in my lifetime I see improvements so that we have treatments that don't come with this cost, to be honest. But it is important to keep in mind that your patients who are on medications for these conditions will have effects of those medications. It's usually possible to consider dose reductions that might limit side effects, but part of living with these conditions, unfortunately, especially in old age, is accepting that the treatment comes with significant side effects. All right. Right, so a few takeaways. I see it's half an hour, so I'm going to move forward and stop there, but I wanted to mention a couple of resources. Of course, the CCSMH guidelines and a few new ones are coming out.
Julia, you can feel free to take a couple of extra minutes if you'd like. That's okay.
Oh, okay, I won't rush then. I don't have any more slides. I'm sure you guys are aware of the CCSMH guidelines, and there's some older ones. There's lots of updates that are coming out. So the BPSD guideline is coming out very soon. Dr. Feldman and I were part of that, and I think it is going to be quite a helpful resource in terms of guiding treatment. I still refer to adult guidelines. So where we don't have detailed older adult guidelines, I often use the CANMAT or adult guidelines that are available. You know, ultimately, like that's how we determine or that guides our treatment if there's an absence of evidence in older people. And then I wanted to mention Dr. Khan has a book. It's pretty old, but it's still a nice resource in long-term care. I'm not sure I should be doing this presentation. He's the expert, but I wanted to mention that's the green book there. And then I really love RX Files too. Not only the book, but look for their newsletters. They have these newsletters or summaries, they call them, and they're really, really helpful, like kind of 2 to 3 page overviews of almost like everything you would need to know, often including non-pharmacological or other, you know, investigations, things like that, you know, when it comes to common problems, not in long-term care specifically, but often, you know, still applicable in long-term care. Okay. And then, oh, I did want to mention, I chaired this committee that developed the standards for mental health and well-being in long-term care settings and assisted living. So I hope that you guys have heard about this. If not, you've heard it here first. This is coming out in summer of 2024, and it's going to offer some very practical guidance. It's very, very detailed, but it's an ideal. It's a standard. So it's what we're aiming for. And if you're thinking like, what are ways to actually do mental health promotion? There are some very detailed standards on what that looks like when we're talking about all residents and what we're thinking about people on a continuum. So watch for that. You can sign up for their mailing list. They send a lot of other foreign stuff. You'll probably hear about it when it's out. It's going to be June or July. All right, this is a mountain I actually did climb. Not as big as Cascade, a bit more manageable in California. And I'm happy to take any questions before the case discussion.
Thank you. That was very impressive. I was going to say metaphorically, I think you climbed the mountain of mental health in long-term care too, Julia, but
Thank
this is a
you.
real
Yeah.
man. That's pretty impressive. There's so many things about the talk that I love, the theoretical framework, and then also it's very obvious that you do this for a living, that you know that just writing in the order somewhere, exercise every day isn't enough to actually make things happen. We have to think about things in a comprehensive way and care plan and all those things. So thank you. This was great. Let me ask if I can, if folks have questions that they would like to ask Dr. Kirk. And please feel free to either raise your hand in the Zoom if you would, so that your face comes up to the top of my screen, or put something in the chat. I'm also okay if you just want to unmute yourself and shout out.
I see a question about whether there's
Yes, from Wendell. Wendell, do you want to speak to that?
Sure. Just had to switch over to my mic here. Yeah, I'm wondering if there's societal reasons behind why mental health is being treated less in seniors. And one of the things I mean is like, from one area, I could see it being because of a stigma attached. So if, for example, we now think that 10% of the population has ADHD, but that certainly doesn't get registered in seniors. And then for another reason, it would be that I could see is that, is there more prevalence of mental health issues now than there was in the past, or not?
Yeah. We think that it's going up, but there's not, clear, we don't have really clear data on that, but I would say in general, the thoughts on perspective or prevalence of mental health is that it is, going up. There's again a variety of reasons. That's partly better recognition in younger people, right? You know that if you have residents that are like in their 80s and 90s, they'll often tell you, oh yeah, well, I or my mother or whoever, definitely had like severe depression, but we didn't, she just took to her bed and there was no like diagnosis or treatment of depression. The generation that's coming in is going to be much more literate and savvy. No, it's not, I mean, it's by no fault of their own older generation. It's societal, right? It's what we recognize. So we have increasing recognition. It's not necessarily that we have an increasing prevalence of the problem overall, but then there are many other reasons why there's a higher, prevalence in long-term care settings. As to the societal reasons, I mean, I agree, Wendell, with what you said, and I would say like a major societal force. I'm not sure if it's societal or what it is, cultural, but is the priority that we place on mental health. So mental health is not a priority historically in long-term care. This is a setting, I'm sure everyone here is not necessarily of this mindset, but I think we could probably agree that historically the priority in long-term care has been physical health, right? It's like, above all else, we try to prevent falls. We, treat your physical health problems. We rarely prioritize, like for a whole population in long-term care, mental health, or we haven't done that in the past. And so I think that would be, from my perspective, a major societal reason why treatment of mental health in long-term care has, been, I mean, largely undertreated in the past, under-recognized.
Any other questions or comments that anyone would like to make? David.
Julia, that was a great talk. Can you say a few words about the standards document that you've worked on, and just sort of what approach it takes and how it might have impact?
Thanks, David. So the standards, so if people are probably aware, they've been hearing about standards development in Canada, hopefully again. So there was a standard, HSO has a long-term care services standard that came out maybe a year, a little over a year ago. And CSA has another standard. Just to clarify, HSO and CSA are standards development organizations, and this is how standards are made in Canada. It's regulated. And so the government says, we want a standard, or someone says, we think we should have a standard. And it goes to a standard development organization to do the work of creating that. And a standard, the goal is to identify what's ideal or an expected level of care or performance. That's really important in Canada. Canada is actually one of the very few countries that does not have standards for long-term care, and it's really problematic. And everyone here can tell me how it's problematic, because if you live in BC versus Saskatchewan versus, let's say, Ontario and Toronto, like, the care that's provided in long-term care is often very, very different. And part of that is the funding is different, staffing models are different. And what drives some of this is a lack of standards in Canada. Like, everyone's doing their own thing. So the goal of standard is to, set an expected level of care to allow, something for people to work towards, and to have more similar care happening across Canada, and people knowing what that looks like. So the move towards, we know this is a problem, and it was all highlighted in the pandemic. And that's really what spurred the move towards standards development in long-term care in Canada, is that the pandemic highlighted all these issues, which everyone here knows were not new, okay? But they were brought to the forefront, and the public became much more interested and invested. And so in the wake of the pandemic, there's been this movement towards standards. There's going to be 3 that apply to long-term care, but it's really 2, the HSO and this one, that are probably most relevant for care overall. And this one, I think, is important because it focuses entirely on mental health. So while the HSO standard has some things that I would say, be indirectly related into promoting mental health. So for example, like personalized care, staffing, etc. This standard focuses entirely on mental health for all, for people who have a condition and for people who don't. I think it's important in that it really prioritizes in a way that I mentioned hasn't been done in the past, that, this is equally important to quality of life in long-term care as physical health. What it actually looks like is, it's a very long document. There are sections. So there are sections on organizational culture, on environment or the physical environment, on younger residents, on residents with mental health conditions, education and training. And within that, there are individual standards that are meant to be kind of the ideal that would be expected, if we were to sort of implement a mental health standard, for all long-term care. Anyways, watch for that. It's quite like I said, a large document. I really don't think it's realistic that it would be implemented in full. It is idealistic in a sense, but I think it is a starting point for working towards. And like I said, it gives an idea for if you were to focus on mental health promotion, like, what would that look like? What would that look like at the leadership level? What would that look like at the staff level? What would that look like at the resident level? So anyways,
standards are really nice because it's in a way aspirational, but if you don't know where you're going, how do you know when you get there, right? It's really important to have those sort of guiding lights to say, well, this is where we should be aiming. What's the first step that we can take? What's the next step? What's the next step? So I really appreciate hearing that this is coming out, and look forward to seeing it. Thank you. Thank you. Megan, I see you put a very nice comment in the chat. I don't know if you want to add anything to that. Megan Wallace. Just, I think, reinforcing the idea that, yeah.
Thanks, Megan. And one thing, so we did consultation sessions for like stakeholder consultations, and I facilitated those nationally for this standard. And I have to say, like, one of the loudest things that came through from people, both residents, care partners, long-term care staff, was the lack of one, the lack of resources, but also the lack of integration. So the fact that like getting, if you need specialized mental health services, that it's just like so hard. It's as if long-term care is like they're in a different healthcare system that, even if you had services in the community, for example, often those don't transition with you to long-term care. So it is like a major challenge that requires almost like a whole paradigm shift, but definitely something I heard over and over again was how challenging it is to get, support services for mental health and long-term care.
I'm just curious, we have over 100 people on the webinar. Does anyone work somewhere where they feel that things are actually integrated and not compartmentalized? Is there anyone who could share with us a model that actually has been successful in doing this? Can it work? Does anyone have that?
Not in a complete or full way. The only thing I could speak to that we're have a relative degree of integration. But again, it's psychological supports for mental health is coming from myself, which is a chaplain, and from external people too. And so where I've seen that chaplaincy model, I think it's something, but it certainly is nothing that would compare to a full access that you'd have in another site.
Thanks, Wendell. Okay, well, maybe at this point, just being mindful of the time, I wonder if it would be a good time to shift over to our case, and then hopefully we'll have some time for more conversation afterwards as well.